Hey everyone, can you hear me?
Yes.
Yes.
Great. All right. So thank you everybody for logging on. If you can, please put your name in the chat. If you do not put your name in the chat, we are not going to have your name on record for attending. So we would love for you to be on record for attending. So please put your name in there. Kristen's going to be monitoring the chat for me, but I'm going to be talking for a bit at the beginning. Then towards the middle slash end, I'm going to run through some scenarios. So I would love for everybody to definitely be involved if you can. If you want to throw things into the chat too, that's great as well. Um, Before we get started, are there any questions or concerns? Okay. All right. If you don't mind though, if you have loud, I don't know, screaming children, dogs, things like that, that might be distracting for other people, feel free to mute yourself as well. I have been on many meetings where I've had a screaming child in my room, so I understand that sometimes you've got kids and things going on. All right, so we're going to start just talking about the rapid response team. This is kind of an introduction. This is not live yet, but this is kind of the end, towards the end of the education that has to do with the rapid response team. Okay, so why do we want to do rapid responses? Um, have you ever had a patient that's maybe not coding, but you know something's not right? Right, you get that gut feeling that's like, man, they have a pulse, but they might not have a pulse for very long if we don't intervene. Has anybody ever felt like that?
Yeah.
Yes.
Yeah, I see some
Yes.
nodding of some heads. I love this little meme in here that's help, I need an adultier adult, right? That's kind of the help, I need a nursier nurse sometimes. But that's kind of the idea. And this stemmed off of the code committee talking about some things, but also we've had people in the past that said, hey, my patient had a pulse, but I needed help right now and I didn't know what to do. So that's what kind of a rapid response is. So it's likely all of you could have looked retrospectively and said, hey, this person could have had a better outcome. Maybe they didn't worsen or died during their hospitalization, but man, we could have done something. I can tell you from one of my very first patient codes, I had that gut sense on a patient about 11 p.m. And I was like, man, something doesn't seem right with this patient. I didn't have any vitals that really said, hey, this is something wrong, but he ended up passing away at by 4 in the morning due to a septic bowel. Okay, so sometimes we have those patients that we want to intervene as soon as possible. Okay, there are often really clear warning signs of deterioration. Not many people are just going to fall over. The only people I can think of are like the big STEMIs, right? The big heart attacks that all of a sudden just pass out. Most of the time, you can see it in your patients. There's something going on that's not quite right. Okay, so what is a rapid response going to do? It's that teamwork that's really critical. Okay, and there's lots of great evidence that rapid response work. The first people that actually did the rapid responses was Australia. They were the first ones to do the rapid response in one of the bigger hospitals. So they looked at their data for over a month, and their number of cardiac arrest in that month went from 63 to 22. Their deaths from cardiac arrest went from 37 to 16. Number of days in the ICU post arrest went from 163 to 33. That's a huge drop. This one I think is super interesting. Number of days in hospital after arrest, 1363 to 159. Huge decrease, right? And then inpatient deaths, 302 to 222. My first time I was teaching this class, I was like, after all those numbers, you're like, oh, that's all with inpatient deaths. But then somebody in the class was like, well, that's 80 people that lived, right? That's a huge number, right? When we think of it. So then they moved to New York was the first place in the US to kind of do this. And their data showed that 50% reduction in non-ICU arrests, reduced post-operative emergency ICU transfers and deaths, reduction in arrest prior to ICU transfer, 4 to 30%. That's huge. And 17% decrease in the incidence of cardiopulmonary arrests. Okay, so there's great data that all this works. I've been a part of other hospitals that have implemented rapid responses. And the goal is to decrease the amount of codes. And the first rural hospital that I helped with do this, we saw a huge decrease where we actually in the first year did not see any codes, knock on wood, right? But huge decrease because you're trying to catch things early enough. Okay, so something to think about. So what is it going to look like? First, you have the person that says, oh man, something's not right. So they're going to be the activator. That activator can be a floor staff member, a tech, and I know that we have a couple of techs probably on our call today. And at the end, we'll kind of talk about the tech role in this. Cardiopulmonary or anyone sensing acute deterioration. Okay, but in general, really the primary nurse should always be informed with prior to calling to really assess that baseline, right? So if I'm the primary nurse and somebody comes in and they're like, man, this patient has stroke-like symptoms, and they start, reacting or something like that. And I'm like, well, they previously had a stroke or something like that, right? So as the primary nurse, I'm going to know best what's the patient baseline. Okay. That being said, I will give a shout out to the techs. Sometimes the techs see this patient more than we do, and they see that active thing happening. They can sometimes be the ones that really see that change, and they should be able to be call as well. Okay, so who's going to respond? Really, that's the people that come to the bedside. It will be the primary nurse, the ED surgery or med surg nurse, depending on the area, ED or hospitalist provider. We're working on kind of who's going to respond where, cardiopulmonary, clinical coordinator, pharmacist if available. This is also kind of dependent, right? If the clinical coordinator's on at the time, if surgery's here, is the ED slammed and they can't provide somebody? Really, that kind of depends. So should everybody in the area respond to a rapid response? What do y'all think?
No.
Not necessarily.
Okay. Why do you think not necessarily?
I think we need to designate a team. I think it might create chaos.
Mhm.
That's just my thought.
Now, have y'all ever been where there's like
but if
30
we have
people
like
that
a
respond?
yes.
That's chaos, right? What is it? What does everybody else think?
I agree with Janine. I think it should be designated, and you should know when you come on shift if you're that person, depending on what department you're in.
Yeah. So it's going to be it's kind of a mix. This is what I like to call the drive-by check, right? If we have a patient on med surg and it's not your patient and you hear a rapid response, you can still go check, right? Because one of two things is going to happen. And we talk about this a lot in BLS, right? Either everybody's going to respond or nobody's going to respond, right? So you could do the drive-by check and see like, hey, oh, they have plenty of people. I'm good, right? That's the kind of idea, but you also don't want to have that many people. And how many other people are on the unit on med surg when that rapid response is going on? Right. So somebody needs to be taking care of the rest of the unit, right? So this is something that like, if you're a designated person on a team, yes, you'll be responding, but also being aware if it's in your area, maybe that's something you check and make sure everybody's good, but don't feel like you need to overwhelm the situation. Okay. I like to tell the story of one time I walked into a Code Blue and there were 7 doctors in the room. Right. And if you've ever tried to do compressions, do the whole thing with 7 doctors arguing at the bedside, it was absolute chaos, right? So the less people, sometimes we just want those core people, but we also want people available if need be. Okay. Activators can be responders, right? Really, the successful attributes of a follower are resourcefulness and humility, right? If you get called to something and in your head you're like, why am I being called to this? That's not something that, we need to act on right now. Maybe that's education later. Really, really responding and helping somebody. The first time I taught this course, I had somebody that had been a nurse over 20 years and somebody that had been a nurse less than 6 months. And when we ran it through all the scenarios, I asked, hey, how many would you call? And the experienced 20+ year nurse was like, I wouldn't call on a single one of them. I would do this. And I looked at the new nurse. I said, how many would you call? And she was like, every single one. Right. So this is, everybody's going to need help at different times. The person needs effective decision making, confidence with compassion, adaptability and agility, right? Sometimes these rapids end up turning into a code, or sometimes they're really weird scenarios. Clear and concise communication. Does anybody remember the specific type of communication we talk a lot about in like BLS, ACLS?
Closed loop.
Great job. Closed loop communication. I was waiting for it. I knew it was
Nice work.
coming. So yes, closed loop communication is so important in these because I'll talk about it later, but the communication is so important in keeping a calm environment, right? I like to tell the story of the time that I was yelling for a crash cart in the ICU and I had to yell 3 different times. I was like, hey, can somebody get me a crash cart? To the point where I finally walked out of the room and they were like, yes, somebody went to go get you the crash cart. They're on their way. Where if that person looked at me and had said, hey, I will get you a crash cart. Or from my side, if I had said, hey, Kristen, go get me a crash cart. And Kristen would say,
Okay, Abby, I'll go get your trash cart.
they're in the room with me, so I can pick on them. That's exactly how that should go, right? It's to really have that successful kind of environment. The person needs critical thinking and problem solving. Does the responder have to have ACLS or PALS? What do you think?
No.
No.
No. Good. Why do you think that?
Because if they have
Sometimes-
yeah. Go ahead.
Oh, you go.
Go for it, Janine.
Because anyone that's been trained in BLS can do compressions. I
Mhm.
mean, just for example.
Oh, great. Yeah.
so.
You know, there's not just even compressions with rapid responses. Anybody can take vitals. They can be helpful in those kind of situations.
Sure.
They can be runners, right? I also like to bring up an
Yeah.
ACLS. How often does people run a code when they have ACLS sometimes? Probably some people never. When I teach ACLS, I'll be like, hey, how many of you have run or been a part of a code in the last 2 years? And I would say 75% say they have not, right? So just because you have ACLS or PALS doesn't mean you can run it by yourself kind of idea, okay? Does it help? A little bit.
Yes.
Yeah, it helps, right? But it's not a requirement. All right. So now we're going to talk about the detection signs. This is all the signs of deterioration of an adult. So if you see an acute change in heart rate to less than 40 or greater than 130 beats per minute, acute changes in systolic blood pressure to less than 90 or greater than 180, acute change in respiratory rate to less than 8 or greater than 28. And this is the point where I love to bring up, this is an acute change, right? How many of our like little old COPD ladies are, you know, trucking away at 30 breaths per minute at baseline, right? Some of them do that. So there's no need to like call on, oh man, that patient's 30. It's that acute change that we're really worried about. Acute and persistent change in oxygen saturation less than 88% with oxygen or non-invasive intervention. It used to be 90%, but we've kind of decreased that to 88% because some people, like our COPD patients, kind of live at that lower level. That also means that we could be like throwing oxygen on them before we call, right? This should be like oh, you're 85%. Let me put you on 2 liters and see how that kind of reacts. One of my favorite nurse residents I've ever had, he called a rapid response because he could not get his patient up. The patient was 82%. And he was like, I keep upping it and I keep upping it. And we go to plug in a non-rebreather and his oxygen cord had unplugged underneath the bed because it was one of those extender connectors. And he was so embarrassed, but it was such a great example of that. Oh man, you keep upping it and you know it's not working, right? So that's a great time to call a rapid response. Upper airway compromise or audible stridor, acute deterioration in patient level of consciousness. Everybody's favorite behavioral emergency. Or staff member or patient is worried. This is kind of a good catch-all of that gut feeling that you might have, but you know, that picture just looks okay, but you have that gut feeling. Acute onset of chest pain relieved by interventions and or a dysrhythmia, a seizure, or acute significant bleeding. Just a reminder for stroke symptoms, you need to call a stroke alert. Does anybody know what's the difference between a stroke alert and a rapid response?
You want the CT ready?
Great. So with a stroke alert, with a rapid response, everybody in radiology is going to be thinking, oh, I wonder what's going on. With a stroke alert, they're going to get the CT ready so we can get the patient down and get them scanned as soon as possible. Okay, so that is exactly why if you call a rapid response and you realize it's a stroke, go ahead and call a stroke alert as well, because you want to get that CT ready. Okay, any questions on those so far?
Nope.
Nope.
All right, everybody's favorite peds. So pediatrics are, as you know, really vastly different. A 1-month-old and a 1-year-old is very, very different. So when we create these outlines for pediatrics, it's kind of a wide range, right? But you also need to know kind of the kid, like age by age as well. But in general, infant less than 1 year old, respiratory rate less than 30 or greater than 60. Heart rate less than 85 or greater than 190, and a blood pressure, any unexpected change from baseline. How easy is it to get a pressure on like a newborn?
Very hard.
Very hard. So if all of a sudden I can get a blood pressure, that's usually an idea to me that something's going on, right? When you have that flaccid arm, they're not fighting that blood pressure cuff. That's usually an indication for me as well. Okay, so a child 1 to 10 years old, such a big range, right? But respiratory rate less than 18 or greater than 30, heart rate less than 60 or greater than 140, or our good old fashion blood pressure measurement there, right? The blood pressure systolic 70 plus age times 2. And then with our adolescents, it's very similar to adults, right? The respiratory rate less than 18 or greater than 30, heart rate less than 40 or greater than 140, and blood pressure less than 90 or really not expected for the kid's condition. Okay. The other one is staff member or parental family concern. A reminder that our parents know these kids sometimes way better than we do. When I teach the talking about in PALS of like urine output, I once had a mom that was like, man, my kid's putting out way less urine than usual. And we're like, the kid has 8 wet diapers a day. She's like, no, it's usually way more than that. And sure enough, the kid was in renal failure. And the mom knew, right? Because the mom knows that baseline for that kid. So if a parent comes to you with that kind of concern, we need to take that into consideration. A patient is lethargic, confused, or has a reduced response to pain. Cap refill greater than 4 seconds. One of the first signs of sepsis is when that cap refill is greater than 4 seconds. Concerning retractions and our good old catch-all, any decline in breathing, circulation, or neurological status. Okay, so kind of a good old catch-all. Okay. A reminder, there are no bad activations for a rapid response. It would be better to be proven wrong. Like, let's say everybody runs in the room and you're like, oh, sorry, everything's actually okay. I mean, if you're interrupting my lunch, I'm going to go back to my lunch. It's fine. If, that's really fine to be proven wrong. We would rather that than anybody feeling bad that they can't call an RRT. If somebody does call one and we were like, man, something should have been done beforehand, maybe some more assessment, this might be some education afterwards, right? In the moment, work through the rapid response. Later, take them to the side and kind of educate them like, hey, you know what would have maybe prevented the rapid response? Let's do a set of vitals before you call, maybe ask for some help, those kind of things. So how are you going to call? If any of the above are noted, you're going to contact RRT needed in room, blah, blah, blah. Okay. You should call down and ask either pediatric or adult, though. So you need to specify either a rapid response or a pediatric rapid response. Why do you think that is? Say that again.
You may get different players
Good.
that have pediatric specialty.
Great. So that's great, right? Depending on who's in house, who can help. The other thing is in the ED, there are now jump bags for pediatric patients. Okay. So if somebody in the ED hears, hey, there's a pediatric rapid response, they're going to grab that jump bag that has more pediatric specific things. Okay. So that's another one that really helps our ED as well. In general, rapid response team should arrive in within 5 minutes. That does not mean somebody's going to be sitting at the door, as you sprint across campus. I mean, if I sprint across campus, I might become a rapid response. So, just be careful as you're going across, but nobody's going to be sitting there timing, but be there as soon as possible, right? And then it's job of the primary RN to use SBAR to communicate the condition of why they called a rapid response. If anybody remembers SBAR, I used it a lot when I was on night shift about when to call for a doctor, right? So this is my favorite SBAR referral. S, summon courage to pick up the phone. B, blur out all the medical words you know. A, agree to all the insults thrown at you. And R, replace hands and cry. I just appreciate that as anybody that's ever called at 2 a.m. in the morning. But when we're using SBAR for this, we're using why are you calling? Okay. The background, the relevant history, right? We don't need to know, that it was their birthday yesterday, that, they have some kind of history that doesn't matter to this. Same with relevant findings, right? We really want the assessment to be specific. And R is pretty big. It's the recommendation. What should happen next, right? What do you think should happen? That kind of guides the scenario, okay? So the idea of the SBAR is, the rapid response happens, the team's all coming in, and we're really looking to that primary nurse to say, this is what's going on in a calm, effective manner, which is hard at times when we're not feeling calm. Okay, so here's an example SBAR. Okay, this is Barbara Manatee, anybody that's ever watched VeggieTales, a 74-year-old woman. She is now hypoxic, requiring 6 liters of oxygen, and is still satting 82%. Background, she wears 2 liters at baseline and was 3 liters at the start of my shift. She has CHF and an oxygen requirement has gone up in the last hour. Assessment, she has crackles in her lower lungs and has increased pitting edema. Recommendation, maybe a non-rebreather, high flow, or Lasix. Okay. What do y'all think of that SBAR? Is there anything you would take out, or what do you think of that? I'm good at awkward silences too. So really, I mean, that's a pretty straightforward SBAR, right? There's not really anything I would take out. There's a couple pieces of it that might not be as important, but really all of it really shows that picture of somebody that's COPD fluid overloaded, right? All right, so I'm gonna have y'all practice. So Cherry Blossom is a 55-year-old woman who was admitted for back pain and abdominal pain, past medical history, hypertension, and hyperlipidemia. Patient has possible gallstones. 8 hours after admission, patient starts to complain about chest pain of 10 out of 10. Is diaphoretic and bradycardic. Provider is notified and is en route after dealing with another patient. 12 lead is done and the following rhythm is shown. How do you feel about that rhythm?
Not good.
Not good.
Looks tombstone-y.
Tombstone-y. Actually, I Googled tombstone to find this one, so it's very spot on. So, right, we're looking at a STEMI. Okay.
Yeah.
So talk to me, what would you think your SBAR would be? Okay. What would your situation be? What's going on here?
Situation, 55-year-old female patient, originally admitted for back pain, abdominal pain, has started to complain of 10 out of 10 chest pain.
Good. Great. Great job, Jessica. So that's our kind of our situation, right? Our background, you know, we could bring up the hypertension and hyperlipidemia. We could bring up that they were admitted, right? But in general, that's not going to be, you can kind of see that background is kind of leading towards that STEMI. Assessment, right? They're diaphoretic, they're bradycardic. Hey, look, here's this 12 lead, right? What would our recommendation be?
Appropriate medications we can do here and transport to a cath lab.
That was a very nice way to say that. I like to call it treat and GTFO. If you don't get out, basically, right? But we're going to treat that, right? We're going to still do Mona. And everybody, when I initially did this one, they were like, oh, we're going to get them out. And I was like, well, we still got to, you know, think of our Mona while they're here, right? Maybe our morphine, our oxygen, our, sorry, I lost my brain. Nitrogen, or what else can we do? Maybe a heparin drip, something like that, okay? So good, that's exactly how you would do an SBAR. So what should happen is everybody kind of comes in the room, they're going to collaborate their assessment findings, they're going to implement treatment as appropriate, and really the important thing is that the provider needs to be communicated with, okay? Because if maybe the hospitalist comes in and it's actually a surgery patient or whoever responds, we really need that primary physician to know as well, okay? Just a reminder though, if it ever like escalates to a cardiac arrest, then you should call a code blue. So the role of the primary nurse is to remain at that bedside, right? I've actually had one of the best CCU nurses I've ever worked with. When she was a brand new nurse, rapid response was called on her patient and she ran to another patient's room. And when we started to talk about it with her, she was like, you know what? I was actually nervous, and that's why I went to go check on the other patient. And she admitted it, and she's now a great ICU nurse. But it's important as the primary nurse that you know that nurse or patient the best. Okay, so make sure to stay at that bedside. We should, you know, contact the physician, use the SBAR to communicate with everybody. We really should be educating and explaining the role of the rapid response to the patient and their families. One of my favorite things to tell patients and families is there is about to be a lot of people in this room that all care about your health. So be prepared, because if all of a sudden they look up and there's all of a sudden 10 people in their room, they can get really nervous. Okay, we're going to be doing vital signs, labs, medication, IV access, blood glucose, all those kind of interventions. And it is the responsibility of the primary nurse to document on the patient's chart as well, which we'll talk about here in a little bit. Respiratory therapist, our cardiopulmonary team, their job is all things airway, oxygen, all the stuff that we love for them to do. The secondary nurse really is coming in. They're that outside view that can sometimes do that critical thinking, that can do the supporting, really to assist the primary nurse as needed. If the clinical coordinator is on, they're going to be making sure all the rapid response team is there. They're going to work on all those kind of pieces that kind of catch all, whether it be the family, the physician, the education, the critical thinking. But the other things they can really do is gather supplies, right? If we need something from downstairs or somewhere else, maybe they can go get it, those kind of things. The arranging the transfers or organizing the debrief section. If obviously the clinical coordinator is not there, that will fall to either the primary nurse or someone else. So for our techs that are on, really the response of the techs, they can help call. They can get supplies, whether it be the crash cart, the glucometer, any kind of EKG, any of those things. They can be the runners to go get that. Assist with IV/IO access, prepare for CPR if needed, and watch the floor and the other patients. So if you're a tech, maybe you go in there, you see what's needed. If you don't see a glucometer, that's the one everybody always forgets in rapid response, is to check a blood glucose. Go get that glucometer, go get the things that are needed and kind of help with that. That's really helpful. So environment is super important. We've been talking about this, that closed loop communication, everyone staying calm, and the important thing of no yelling. Okay, nobody yells angrily most of the time in these kind of situations. What happens is you start yelling across the room, right? Hey, so-and-so, can you get me this? And then Kristen's over here talking to Wendy, so they're going to start talking louder. And so the whole sound gets much, much louder. So just being purposeful and keeping calm and keeping our voices calm is very important. What are the barriers to an effective rapid response? Conflict. I've seen before that's like, hey, I've called this doctor 3 times throughout the night and I didn't get what I needed, and now we're in this situation, right? That's conflict between the nurse and the provider that can cause issues. Lack of coordination. Distractions. I've had times, most of the time we like family in the room, but I've had times where maybe a family member is inconsolable, maybe screaming. I've had moms and kids, patients that do that, and you want to take them out into the hallway, support them where you can, but having that be less of a distraction. Fatigue. Nobody's ever fatigued at 2 a.m. on the night shift, right? Workload. Whether you have 5 patients, the ED's full, you have only 3 patients, but your main patient is Grams that keeps getting out of bed and is causing all kinds of issues, right? Your workload can take away from that. Misinterpretation of cues and your lack of role clarity. Okay. Debriefing. Really, this is important. Whether it be the official debrief form or hey, this is an issue we saw and we're going to contact our leadership or our educators to really work out an issue, okay? Because the goal of the leadership and the code committee is really to assess trends, education needs, and overall quality improvement. Great example of this is when I sat on the code team at another hospital, we saw 5 different rapid responses all in 1 month, all on the same physician's patients, all seeing them hypoxic and low respiratory rate. Okay, we were like, why all of a sudden all 5 of these? So we started to look at it, and he had recently changed his order sets, and they got misinterpreted when they got put into Meditech. And what was happening is IV pain meds were being ordered at the same time as muscle relaxers. And sure enough, about 2 hours later, we were given Narcan 5 times in a row. So we were able to look at those trends and be like, oh, hey, let's update, let's find that mistake. Okay. So that's where it's important for y'all. If y'all see something, you're like, man, this seems to be an issue. This could have been improved. And then a week later, Janine has a different issue. And she's like, hey, I saw this issue. And as the leadership in the code committee, we can be like, oh man, that's an overall trend. Okay. So don't be afraid to say, this is something that worked well. This is something that definitely did not, because we want to be there to support and find ways to improve. The documentation will be in Meditech and will need to be added to the work list. It literally is rapid response documentation. It should be done by the primary nurse. There's lots of pieces of that documentation. There's vital signs, interventions, but the two most important things that need to be documented and are required is why was the rapid response called and the outcome of the rapid response. Outcome could be they stayed on the unit, they got transferred to higher level of care, or hey, they ended up being a code. Okay, that's good for us as the code committee team because we can look and be like, man, the last 5 rapid responses ended up becoming a code blue. What can we do to help prevent that? Yeah. All right, this is your reminder. If you have not put your name into the chat, please put your name to the chat to get credit for being here. You will not get credit for being here if you don't put your name in the chat, so please do that. That would be great. All right, so now we're going to run through 6 different scenarios, okay? 5 for the nurses, 1 for a tech. What I'd love everybody, if you are on mute, if you want to give feedback, really appreciate that. But let's talk about these 5 cases. The first one being in med-surg. If you didn't notice, I really enjoy making my patient names. So 99-year-old female, Terry Dactyl, was transferred from Valley View Hospital this afternoon as a swing bed patient after an infected right hip prosthetic replacement. You're seeing the patient around 8 p.m. after shift change. She keeps saying, "This is the night the Lord takes me home, and I'm just ready to see dear Harold." The daughter is at the bedside and is very concerned. She asks, "Is there a team you can call? I'm worried about my mother." If you're not comfortable talking, you can also write things in the chat as well. What do y'all think?
Investigate why is she concerned and do a set of vitals.
Great job. Yes, right. This just because somebody says, "Hey, call something, call that." Yeah, it's great to see vital signs. Is there anything else we want to know about her?
Her history.
Her history, good.
Mhm.
Her history, because is this her normal? Does she sundown at night? Right. This is a pretty good picture of sundowning as well. Anything else you want to know?
An assessment.
Say that again. I'm sorry.
Assessment.
Yeah, your assessment. How does she actually look? Right. Anything else y'all can think of? What do you want to know about a 99-year-old?
Is she a full
Code
code
status.
Code
Code
status.
status.
Great job. Right. So code status is the big one. But yes, all of those things. If I take vital signs and her blood pressure is 120/80, whatever, she's doing fine. She's sundowning, right? If you go and her blood pressure is 60/30, right, that could be a rapid response. I like to bring this up because there are other hospitals that will not call rapid response on DNR patients. But this is a reminder that DNR does not mean do not, or it means do not resuscitate. It does not mean do not treat, right? So this, if let's say she's actually needs a fluid bolus because she's actually hypotensive, right? We can call a rapid response and that's a good reason. But it's better to get all your ducks in a row. Like y'all said, find all those pieces, but a good reminder that just because they're DNR, we can still call rapid responses on them. Great job. All right. Cardiopulmonary. A previously healthy 14-month-old boy, Chris B. Bacon, was admitted due to dehydration and hypoxia. Sorry, I can't see my words. The child has had a fever and cold-like symptoms for the past 2 days after Big Sister came home from school with a cold. The child's mother, Burnt Bacon, brought the child to the ED due to difficulty breathing, stridor, and fever. Child received racemic epi and oral Dex in the ED. Patient was placed on half a liter of oxygen for hypoxia, and the child was admitted for observation. Any concerns so far?
Dehydration.
Yeah, maybe some
Yes.
dehydration.
Fluids, yeah.
But overall, it's kind of
Fluid
a good
status.
picture of croup, right?
Mhm.
Right. I feel like we do this a lot. We admit them for obs just because they needed a little bit of racemic epi. If y'all know, racemic epi is really fast half-life, right? So we usually admit these observation to make sure that their Dex and the racemic epi meet, right? Because the Dex takes maybe 6 to 12 hours. Those racemic epi drops sooner. So sometimes we just admit these overnight to make sure that they're good. Okay. Cardiopulmonary, though, then goes to assess for another treatment. Child is noted to have severe retractions and a respiratory rate of 18, pulse rate of 110, oxygen saturation of 72%.
Ooh.
I hate to say, but any concerns there?
Yeah.
Yes.
Good. If you didn't say yes, I'm worried. No, I'm kidding. Yeah, right. A respiratory rate on these kids, usually a 14-month-old is usually between 28 and 32 is what we like to see. So all of a sudden, a drop in respiratory rate is a huge concern. So are there airway issues? Do they need high flow? As we're coming into PED season or already in PED season, a reminder that a drop in respiratory rate or heart rate in children is detrimental. Okay. If they were trucking away at 180 and now they're 110, they're losing their compensatory. I always mess that one up. Compensatory methods, right? So if they all of a sudden have that drop, that's when we're worried. Okay. A big thing, kids usually die from respiratory reasons and not cardiac reasons. One of the first times I taught this class, there was a respiratory therapist that would be like, I probably wouldn't call a rapid response. I would go get the high flow. It's like, okay, cool. Who's in the room when you go get the high flow? And he looked at me, he's like, gotcha. That's when I would call. And I was like, you want to call to get all those people in the room so we can get the high flow set up and everything going. Yeah. Alrighty. Next, med-surg. Chuck Taylor is a 62-year male who's been admitted due to fevers of unknown origin. There's a suspicion for possible pneumonia. Chuck's home medications include vitamin D, metoprolol, Lasix, Lipitor, Flomax, lisinopril, atorvastatin. We never see any patients with those. At 9 o'clock medication pass, patient did not take any medications due to not feeling well and wanting to rest. At 2 p.m., patient's vitals are a temp of 101.2, respiratory rate 28, heart rate of 90, blood pressure 100/68. Patient's alert and talking to you, but doesn't feel well. Any concerns so far?
Fever,
Yeah.
respiration,
Good. Fever, respirations.
sepsis.
Good. Sepsis.
Mhm.
Okay. Any other concerns?
Mm,
If somebody that usually takes their 9 o'clock blood pressure medicines all of a sudden doesn't take them, where do you expect their blood pressure to be?
higher.
Higher.
Oh, way higher, right? We're talking like 210s, those kind of things. So if all of a sudden we see that huge drop in blood pressure and we're like, man, that's not what it should be when they don't take their medications, that should be a sign to us. That's important of looking at trending. Okay. So this is a good reminder. None of those vital signs are triggerable on our rapid response like the protocol. But did everybody kind of get that gut feeling something's not right?
Mhm.
Yes.
Good.
Yeah.
Question for y'all. No right or wrong answer. Would you call a rapid response on that?
Treat the causes
I
first.
wouldn't. I probably wouldn't. No.
No.
I agree. Most people say that they wouldn't, and I completely agree, right? If you can do some interventions beforehand, that's where we want to kind of intervene. But let's say at 6:55, because we always know it happens at shift change, patient's vitals are 103 temp, respiratory rate 42, heart rate of 140, blood pressure of 60/30.
Ugh,
Yeah.
that's definitely rapid response.
Yeah, that's more rapid
Criteria.
response worthy, right?
Yeah.
So yes, if you have that gut feeling, and let's say brand new nurse, 3 days off of orientation, has that 2 p.m. kind of feel, and she's like, man, something doesn't feel right. I need help now. I think it's appropriate they can have that rapid response. But if you as a nurse, you're like, man, let me try. Let's get some lactic acid, some fluids. Let's get some other things going. That's the good way to go. Okay, so just because you have these parameters doesn't mean you should just rely on those, right? It's not textbook. We can all look at a patient's trends and kind of figure things out as well. Okay. All right, the ED. Do I have any ED nurses on? Sometimes when you feel it. No.
Yes, I'm here.
So this is a good one for y'all. It is 2 a.m. and every single room has a patient. Never happens. It's also a lovely full moon out. 32-year-old female, Isabella Ringing, is coming in complaining of abdominal pain and fatigue. She decided it was time to be sober 2 days ago and was not feeling well since. She has no prior medical history and was drinking about 1 liter of peach vodka a day. Any concerns? Besides the fact that I don't know why I put peach vodka, but I feel like that's like psych worthy to drink 1 liter of peach vodka a day. But Any concerns so far?
Withdrawals, pancreatitis.
Withdrawal risk. Mhm.
Yeah, withdrawal.
Mhm.
That's the big one. Anything else?
Pancreatitis.
Abdominal pain. Yeah.
Great. Thank you for bringing up pancreatitis. One of my last big codes was actually a 32-year-old female that had a ruptured or she had a cyst on her pancreas that ruptured as she was trying to detox. So, right,
Mhm.
I'm glad you all brought that up. Okay. As you were walking by the room, you noticed the patient's on the floor having a seizure. Your ED provider's in another room with the other nurse intubating the patient next door. What do you do?
Ativan, rectal Ativan. Yeah.
Recovery position, protect your airway,
Yep.
yell for
Yell.
help.
Can you do the rectal Ativan too?
I think you can now.
Oh,
Rectal
I don't know about Ativan. Valium.
Valium for
Or
sure.
if they or Valium,
Yeah.
yeah.
Yeah. So ED nurses are a little bit different. You usually have people come in unstable. You usually have these kind of scenarios where those parameters don't really make sense to you. The best time to use this in the ED is, oh no, I need help. Okay.
Mhm.
And somebody actually told me, they were like, I don't know if I could get to a phone to call a rapid response. I'd call a code blue. I think it's appropriate, right? If you need help down there, you need help with this patient who, usually when people have a seizure from withdrawal, what kind of outcomes can happen if we don't treat them soon enough? Do you know? It's good old torsades de points.
Yeah.
Right? It's that lack of mag.
Mhm.
So, right, if you need more hands on deck, go for it, right? That's a great time to either call a rapid response, call a code blue. This is the same as the OR. I'm doing some specific OR training as well, because they usually have an anesthesiologist right there until it's 5 p.m. and everybody's gone home and they're in the PACU with the patient, right? So just use those, use the rapid response as you need kind of thing. This is actually one of my husband's ED patients. The patient had a seizure, but they were over 400 pounds, fell off the bed and rolled in front of the door, and it took 8 people to get the door open. I know. So, yeah, I like to bring up random stories. All right. Infusion. 48-year-old male, Barry Kuda, is coming in for his first daily antibiotic infusion. Patient appears really anxious when coming in for the infusion. All vital signs are normal and the patient's infusion is started. 10 minutes into the infusion, you notice the patient seems to fall asleep. You know the patient's breathing becomes slow and shallow and respirations are 4. I don't know about y'all, but I don't like counting respirations to 4. I feel like if I'm waiting for that 4, I'm like, oh wait, that's way too slow. So what are you gonna do?
Slap on some oxygen and call for help.
I like it. Is that Shelly, is that literally slap the patient with oxygen? Or... No, that's exactly it, right? Getting that help. Usually you need somebody that's going to kind of tell the story, right? Figure out why are their respirations so low. So this story actually comes from Valley View Hospital Procedures. I heard about this story. The wife admitted to giving the patient some of her anxiety medication because he was nervous about coming in for the infusion. She says she gave him 3 Xanax.
Oh boy.
And what he did is he was supposed to have 3 infusions over 3 days, and he decided to take all 3 at once.
My
So,
God.
right. But can you
Sure, he's
imagine
got an
as a
air
nurse by
raid.
yourself, are you able to manage that airway and
No.
try to figure out what's going on at the same time?
Mhm.
No, that's where that teamwork really is so important.
Yeah.
All right. Do I have any techs on the line?
That's our CNAs.
CNA, sorry.
We've got a few.
We've got a few. So this is a good one for y'all because I feel like this happens, right? You're helping hemorrhoids an 89-year-old woman to the bathroom. After sitting on the toilet, Hema slips over and becomes unresponsive. You check and she has a pulse and she's breathing. As a tech, what do you do? Thanks. Yeah, you call RRT. I saw it in the chat. Call for help. Right? If you can't call an RRT, this is when you start yelling for help too. Right? We have people vagal all the time, and sometimes you run in there. As nurses too, you run in there to go help the tech, and all of a sudden the patient just sits up and they're fine. Right?
Yeah.
But that I feel like that's a great tech scenario of like, hey, something happens. I need help right now. you can call a rapid response. All right, so we're wrapping up here. Just a reminder, if you didn't put your name in the chat, please put your name in the chat to get credit. When will this be starting? To be announced. We're finalizing some of the final details as the code committee. Be looking. We're going to start some mock RRTs and code blues starting this winter at some point. Really making practice makes perfect. So we'll let you know what days. It's not like at some other hospitals where it's going to be like we just show up and do a code blue or mock RRT. We're going to announce when we're going to do them so that way people can come and be involved if you want to. Okay. Any questions, concerns, feedback?
Thanks for doing a makeup day.
Yeah.
No, thank y'all for being on. I
Thank you.
appreciate it. Thanks for those who interacted. That helps a lot too.
We still
Great.
have 3 people who are on, but haven't put their names in the chat.
Okay, so please a reminder that put your name in the chat. Really helpful. All right, thank you
I
all.
think-
Sorry,
yeah.
go ahead.
Oh, mine's in there, right?
Yes,
Yeah,
I
we
put,
got you.
okay, just double checking. Okay.
we're missing Joanne, Sophia, and Tanya.
There's Tanya. So Joanne,
Hey.
Sophia, if you're on, if you can put your name in the chat.
Abby, I was gonna ask if has this been sent in an email as like a PowerPoint so that I could review it? Because I only caught the last few scenarios. I'm so sorry.
So there will be a health stream, but we can also send that out as well. I can have
Okay.
Melissa attach it in the weekly updates.
Okay, that would be helpful just because like it's nice to review.
Yeah, for sure.
Was that Sophia?
That was Sophia.
Okay.
So will we have to add this onto our work list for our RT, like if it occurs, or does it just,
Yeah, it will be something that you need to add.
we'll add on? Okay.
Yeah. We
Great.
thought about adding it onto every patient, but it's a even more work list items for something you might use every once in a while.
Sure. Yeah. Okay. Cool.
Great.
On
Any
a-
other questions?
When this gets rolled out on a day-to-day basis, will there be a document or like a little board where you can see people who are going to be part of the RRT that day, or is it just kind of up to each unit to decide who they're going to send?
Great question. I don't have the answer for yet. That's kind of some of those like logistical things we're finalizing is each unit's going to be a little bit different. Like the OR is going to be a little bit different, but there's talk of how to do that. So it might be something the CC does. It might be something that's kind of more natural. As soon as we know, we'll definitely post that out. So you know.
Awesome. Thanks.
Okay.
All right. Anything else?
No, that would be. Thank you.
All right,
Thank
y'all
you.
so much. Y'all have a great day.
All right.
Thank
You too.
too.
Okay. Bye.
Bye. Bye.